All right, so acute respiratory distress syndrome, or ARDS, by Nick Riesenberg. This is the third video in our video assignment talking about ARDS and prone positioning. So anatomic alteration of the lungs. ARDS causes the pulmonary capillaries to become engorged and the permeability of the alveolar capillary membrane will increase, which causes interstitial intra-alveolar edema as well as alveolar consolidation. These all contribute to a decrease in alveolar surfactant and atelectasis. The major pathological changes are interstitial and intra-alveolar edema and hemorrhage, alveolar consolidation, intra-alveolar hyaline formation, pulmonary surfactant deficiency, or qualitative abnormality, and atelectasis. So etiology and epidemiology. ARDS accounts for 10% to 15% of all intensive care admissions and 25% of patients receiving mechanical ventilation. That's pretty big numbers. Thinking about all the things people come in with, that amount is pretty substantial amount. More than 60 pulmonary insults have been identified to cause ARDS. A few count for most of the cases, and those are sepsis, aspiration, pneumonia, and severe trauma. So in continued, patients typically present with these symptoms: dyspnea, cyanosis, bilateral crackles, tachypnea, tachycardia, diaphoresis, and use of accessory muscles on inspiration. So diagnostic criteria. To diagnose ARDS, the first step is rolling out other possibilities. Cardiogenic pulmonary edema is the primary alternative that should be ruled out, just because they can kind of mimic each other. So you want to make sure that you rule that out first, that that's not the cause, that you know that. So that leads you to thinking it could be ARDS for sure then. The Berlin definition of ARDS diagnostic criteria states respiratory symptoms associated with ARDS have manifested within 1 week of a known clinical event or new or worsening symptoms over the last 7 days. To define the severity of ARDS, you must determine the severity of hypoxemia. To determine the severity, the ratio of arterial oxygen tension to the fraction of inspired oxygen ratio is used, or better known as the PF ratio, which is PaO2 divided by FiO2. So a mild case of ARDS would be over 200 in that PF ratio, but less than 300. Moderate would be over 100, but less than 200. And severe would be less than or equal to 100. So clinical manifestations of ARDS, they could be from shortness of breath, low blood pressure, confusion, because if you're not getting oxygen, you're not going to be getting oxygen to the brain, so you're going to be confused. Extreme tiredness, same thing. Labored rapid breathing, also the same thing. If you can't get enough oxygen in there, you're going to have some trouble breathing. So general management of ARDS starts with the 5 P's of ARDS therapy: perfusion, positioning, protective lung ventilation, protocol weaning, preventing complications. So perfusion ties into what we were talking about in the last video, that blood flow. So blood flow is needed to perfuse. You can't have oxygen being perfused through the capillaries and picking up CO2 from the capillaries if there's no perfusion happening, if there's no blood flow. So that keys in there. Positioning, that's going to be prone positioning, where we're going to talk about here in a later video. Protective lung ventilation, also in another video when we're talking about ARDS protocol weaning as well for that, and preventing complications. We're going to be tied in with that as well. Other ways of general management is sedation and paralytics, because most of these people are going to be on mechanical ventilation. So you better have them sedated with a paralytic and not one without the other. We know that'll cause a lot of problems. Fluid management, you don't want to over or under fluid, give them too much or too little, because it can back up if you give them too much, and it's going to impede on blood flow. And if you give them too little, it's going to impede on blood flow, because that PVR that we talked about is going to decrease because there's no fluid to move. And then ECMO for severe cases, that's kind of a last choice thing. If people are in that bad of a state, ECMO is the only option that we really have. That takes blood out of their system, and we oxygenate it and put it back into the system for them. Like I said, it's a kind of a last case scenario. Not that it doesn't work, it absolutely does, but it's a last resort option. So for imaging here, we have a CT scan on the left, and then a chest x-ray on the right. I'm not as familiar with CT scans, but I think I can basically tell you. So the 2 images on the left, top and bottom, are going to be before. You can see all that white, all that space is just consolidated down there at the bottom. The vasculature is very prominent and filled. Like there's a lot of consolidation. Nothing's really moving. Everything's just sitting sediment. And then in the 2 right images, top and bottom, you see a lot more black, which is going to be air-filled spaces. There's a lot more aeration going. There's not as much consolidation. and you can tell that there's getting more perfusion because of that, because those vessels are not near as engorged and prominent and almost look like a mass themselves. And then in the X-ray on the left, same black indicates air is being there. There's hardly any. That is massive consolidation there. Nothing is getting perfused there. There's hardly anything going on in those lungs, and the lack of ventilation because of all that consolidation and that lack of compliance in the lungs. And then the right, you can see a lot more of that. You can actually make out some of the vascular markings a little bit better, and also the tracheobronchial tree, and you can see the heart a lot better too. You can see it on the first one, but it's kind of blended in with everything because how white that actually is. So that is actually showing from post-proning to pre-proning how much that could really benefit the patient and help them get more ventilation, oxygenation, perfusion going on. So for a summary for ARDS, decreased lung compliance, that lack of surfactant being produced, all that consolidation, all that pulmonary hemorrhaging and edema, that's contributing to a lack of compliance, meaning your lungs are not being able to be filled. They're not getting enough ventilation because it can't go anywhere. They're not going to move. They're not going to operate with that air coming in. And if that's not happening, then oxygen is not getting picked up at the capillaries. And a lot of it is because of that consolidation, they can't really perfuse, and there's a lack of oxygen coming in the first place. So 5 P's of ARDS, again, perfusion. Like I was saying there, you need perfusion, you need that ventilation to come into the lungs, and then for the capillaries to be able to pick up oxygen off of that and then dump off CO2 so we can exhale it and get that out of our system. But with the lack of compliance and a lack of ventilation, you can't do that. Positioning, we're going to talk about a little bit more, but with how prone positioning can help with all those issues there with the gravity involved, and then just taking a lot of work off of the system. Protective lung ventilation. Again, we're going to talk about that a lot more later, but compliance. You have a lack of compliance, which means you can't put a lot of air. A lot of air means a lot of pressure, and a lot of pressure means you can pop their lung. You can cause a hole. You can cause a pneumothorax. You can make things go from bad to worse very quick. So you have to be very meticulous in how you try to ventilate and oxygenate these patients. It's a little bit of a dance, but there are ways to go about it, and scientific ways to make sure that we are being as safe as possible and helping these patients rather than hindering them from getting better. Protocol weaning. With anyone who's on a mechanical ventilation, the goal is to get them off of it. And weaning is how you do that. So we got to wean parameters down and down as they get better, so we can slowly get them to a state that they're doing this on their own, and then we've counteracted the effects of their ARDS or whatever pulmonary condition they're having. And then preventing complications, pretty straightforward. You know, they're already not good. The last thing we want to do is cause more problems by, like I said, with the lung ventilation, popping a lung. You know, if you're moving the patient around, you know, displacing the ET tube or anything like that, we just don't want to add more to the problem. We want to fix the problem. So the key to thinking with ARDS is that there's a lack of compliance in the lungs, and that's the issue. So we have to deal with that very delicately, and it almost like increment amounts to get these people better.